Hi, everybody. Welcome to Webinar Wednesday. We are excited to have you here. We do have quite a few webinars scheduled throughout the summer, so keep coming back this summer as summer creeps up on us slowly but surely here. We had a little bit of a change to our recording mechanism, the way that UND lets us do it and all that. So there might be a little more time it takes to get the videos uploaded so we still record all these webinar Wednesdays, but they probably, normally I would tell you it was Thursday they'd be up. I'm going to say Friday now. By the end of the day, Friday workday, these videos should be posted up on our website in that same spot where you found info to log in and all of that. And the CE request will be up there as well, but we just need to give a little more time to our tech team because of the change. But keep joining us, and yeah, if you ever know of speakers, reach out. We are excited to have Chelsey here, though. Chelsey is a physical therapist and board certified neurologic specialist through the American Physical Therapy Association, as well as the outpatient program director for PAM, which is Post-Acute Medical Health Rehabilitation Hospital, Fargo. She's going to talk to us today about programs that PAM has, along with providing education on how physical therapy and technology can be used to facilitate rehabilitation post-stroke, brain injury, and concussion. So we're super excited to have Chelsey here. Just so you know, Chelsey's screen isn't allowing her to show her and her slides. So we're going to let her show her slides, and then she will come on at the end when she takes questions. We will have her come on the screen, and then you'll get to actually see Chelsey. So right now you'll get to see me on the bottom. So. But yeah, go ahead, Chelsey. Take it away.
Thank you, Carly. Yes, everyone, I promise that I'm here. I just can't pull up my face and my presentation at the same time. So you get to look at Carly, and we'll meet in person in a minute. I just want to thank everyone for participating in Webinar Wednesday today. Like Carly said, my name is Chelsey Asiala. I'm the outpatient program director at PAM Health Rehab Hospital of Fargo. I'll be presenting on technology that can assist with rehab post-brain injury, as well as providing a brief overview of PAM Health of Fargo. So the objectives of my presentation: after listening to this presentation, the learner will be able to recall treatment interventions for decreased ability to swallow, name specialized treatments provided by occupational therapists, list 2 devices used by physical therapists to improve patient function, and name 3 technology devices available to patients with their rehabilitation post-brain injury. Just an introduction about me. I'm the outpatient program director at PAM Health Rehab Hospital of Fargo. I graduated from the University of North Dakota in 2010 with my doctorate of physical therapy degree. I spent 10 years treating patients at Banner University Medical Center, which is located in downtown Phoenix. I worked with patients in the acute rehab settings, something similar to PAM, and then in the outpatient neuro settings, with a focus on treating patients with neurologic and vestibular diagnoses. I moved back to Fargo 2 years ago to be closer to my family. I'm a board certified clinical neurologic specialist through the American Physical Therapy Association, as well as certified in dry needling and power moves, which is a treatment technique to use with patients that have Parkinson's disease. My husband and I have 2 beautiful children that are shown in this picture here. We enjoy spending our time exploring all the amazing outdoor activities our community of Fargo has to offer. So PAM Health Rehabilitation Hospital opened its doors in Fargo in 2020. PAM Health specializes in rehabilitation, long-term acute care, and outpatient therapy clinics, and they're located all over the country. The majority of PAM Health hospitals are located in Texas. The next closest one to Fargo is located in Nebraska. PAM Health Rehabilitation Hospital Fargo is a 42-bed inpatient rehab hospital and is the only freestanding rehab hospital in North Dakota. It is part of the PAM Health Network, which is a group of 50+ rehab hospitals that are located throughout the US. PAM Health primarily specializes in rehabilitation hospitals, which makes it unique. We are accredited by CARF, which stands for the Commission on Accreditation of Rehabilitation Facilities. This is an accrediting body that ensures rehab hospitals provide the highest level of care and quality to patients and their families. It is the highest level of certification a rehab hospital can attain, and it requires a recertification every 2 years. Our hospital has a dedicated brain injury unit. It has 12 rooms, and all of these rooms have en-suites. This allows a caregiver to stay with the patient and help support their rehab stay. We also have a quiet gym, which is a smaller gym area where patients can participate in therapy in a quiet, less distracting gym area outside of our normal large therapy gym. We offer both inpatient and outpatient rehab services, which I'll discuss later. Our therapists hold multiple certifications, including many of them being certified brain injury specialists, board certified neurologic specialists, as well as therapists that are certified to perform certain treatment techniques, such as a FEES, which is a treatment technique to look at swallow function, which I'll discuss later in this presentation. To be a patient in our rehab for outpatient and inpatient programs, you need to be at least 18 years old. Our state-of-the-art gym includes multiple types of technology to assist patients during their rehab stay. Next, I'll briefly describe what inpatient rehab looks like. The goal of rehab is to provide patients the ability to participate in intense therapy with the goal of returning home. A typical rehab stay is 8 to 14 days, with the intent of the patient typically continuing with therapy once they return home, whether either this be with home health or with outpatient therapy. They're typically a team of medical providers available that round on patients daily. This may include hospitalists who manage the patient's medical stay or physiatry. A physiatrist is a physician who manages a patient's rehab care. This is coupled with physical therapy, occupational therapy, and speech therapy, providing at a minimum 3 hours of therapy 5 days a week. Rehab hospitals are the only group mandated by Medicare to provide this level of intensity of therapy services. There are also nurses and certified nursing assistants present who specialize in rehab nursing. Case managers run on patients multiple times a week, and they assist with the transition home. A dietitian is also on staff to ensure all patients' dietary needs are met, especially those who require tube feedings. There are respiratory therapists present to assist with oxygenation and breathing needs. Each patient is discussed weekly during team conferences, where a member from each team is present to ensure each patient is progressing towards his goals and will be successful upon discharging home. A group of clinical navigators help patients transition to our acute rehab hospital. They can make that transition not only from an acute care hospital, but also from home, a doctor's office, the emergency room, or from an assisted living or independent living facility. A patient does not need to be in an acute care hospital to get admitted to PAM, which is a unique feature of our program, and this is covered by Medicare and most other commercial insurances. Our gym has many unique features, one of which is a multi-service ambulation track, and that's what is pictured here. It has various textures such as grass, gravel, and brick, as well as curbs, ramps, and my favorite, a dock, for a patient to practice ambulating on those various surfaces in a safe environment. And we all need to practice walking on a dock because we all go to the lake in the summer. Next, I'll discuss outpatient rehab. Outpatient therapy occurs after the patient is discharged home. Typically, whichever therapies the patient was receiving in the hospital, they'll continue those on an outpatient basis. The therapy team will provide treatment while the patient is at his appointments, and then also prescribe activities and exercises the patient can work on between appointment dates to continue to work towards his goals. Patients can attend outpatient therapy without staying in an acute rehab hospital first. Typically, a patient needs a referral from a physician to attend outpatient therapy. This can also be dependent on the type of insurance carried by the patient. Usually, a patient is seen 2 to 3 times a week for 1-hour visits for both PT, OT, and speech. The frequency of therapy visits is determined by each therapist with the patient and his caregivers to determine the team approach used in the rehab setting. Each therapist develops a plan of care that he will use to help the patient progress towards his goals, which is also discussed with the patient, caregivers, and then communicating to the physician. The plan of care is revisited monthly to ensure the patient is continuing to work towards his goals. Depicted here is a photo of about half of our therapy gym. On the left of the photo, you can see the vector gate and safety system, which is kind of hanging from the ceiling there. It's a device used to help patients during gait, balance, and ADL training. I'll talk more about this device in a little bit. So just a very brief overview of brain injury. There's 2 primary types of brain injury in adults, traumatic and non-traumatic, and these are considered acquired brain injuries. The other type of brain injury is congenital, meaning a patient was born with a brain injury or it occurred during the birth process. Traumatic brain injuries are just that, damage to the neurotissue by a traumatic event. They can be closed, such as a concussion, or penetrating, such as a bullet passing through the skull and entering the brain tissue. Brain injuries can also be non-traumatic, such as a cancerous tumor, a hemorrhagic stroke, or an anoxic event. Anoxia meaning the brain is deprived of oxygen. Brain injuries can lead to multiple symptoms that can decrease function, such as dysphagia, which is difficulty swallowing, severe weakness or hemiparesis, and multiple other presentations. Frequently, these symptoms impair a patient's ability to function and therefore requires ongoing intense therapy at a rehab hospital immediately after the injury, and typically ongoing outpatient therapy once they're discharged home. So next, I'll break into the different types of therapy available here at PAM. Speech therapists, excuse me. Speech therapists can help treat patients with cognitive, communicative, or swallowing issues post-brain injury. Here I will touch on the technology available to help speech therapists assist patients with swallowing. One assessment tool that's available at PAM is called a FEES. A FEES stands for Fiber Optic Endoscopic Evaluation of Swallow. It is performed by a speech therapist, or it can be performed by an ENT, an ear, nose, and throat physician. It is a procedure where a flexible tube with a microscope camera is put on the, with a microscopic camera on its tip is passed through a patient's nasal cavity to visualize the swallow function inside the patient's throat. This procedure allows the speech therapist to do 5 things: examine the anatomy of the person's throat, observe movement of the structures that are needed to swallow, observe secretions and secretion management to determine if the patient is at risk for aspiration, allows for direct assessment of the swallow with liquids and solids, and allows for observation of the therapeutic interventions designed to improve a patient's swallow. Based on the results of this FEES assessment, the speech therapist can help determine a patient's diet, as well as if a patient has difficulty swallowing secondary to an obstruction in his throat or due to weakness of his muscles that assist with swallowing. The speech therapist will communicate their findings to the patient's physician, and they will work together with the rehab team to determine intervention needs and diet for the patient. And the photo depicted is what the FEES looks like. After performing a FEES, a speech therapist may use the treatment device eSwallow, which is pictured on the slide. eSwallow is the use of surface neuromuscular electrical stimulation on patients who have dysphagia or difficulty swallowing. It involves placing electrodes on the patient's neck muscles that assist with swallowing to help improve swallow function. Research shows patients post-stroke and post-brain injury that have dysphagia demonstrate significant improvement in swallow function with the use of neuromuscular electrical stimulation. Next, I'll discuss how occupational therapists can use technology to improve outcomes with patients post-brain injury. This is a picture of our ADL suite, which our occupational therapists use daily. It is set up to feel like an apartment and features a full-size washer and dryer, as well as full-size kitchen equipment. It has a normal height bed and a shower that has a tub. This allows each patient to practice in an environment that is similar to home to ensure they can practice all the skills necessary to be successful once they go home. Most patients practice making food in this kitchen, which allows the occupational therapist to observe how the patient performs and then make recommendations to ensure the patient is safe and successful with kitchen management and meal preparation at home. Next is the NSIR. This is a device used to help patients with visual disturbances that occur with brain injury, concussion, or stroke, and is utilized by our occupational therapists. It consists of a large interactive touchscreen, as well as a balance board to incorporate balance activities into training. The board is what's featured up on the screen. The device can help work on multiple activities, such as hand-eye coordination, saccades, which is the ability to track from one target to another, visual tracking, and visual motor activity. It can also help train the patient on memory skills and balance activities. The results of each visit are stored and then able to be reviewed to track the patient's progress. On this slide is a picture of what the NSIR would look like during treatment. The occupational therapist is able to test and then treat multiple symptoms that present after brain injury, such as inattention, fixation, awareness of peripheral vision, speed of recognition of objects, visual cognitive training, and divided attention. These activities can be performed seated, and then as the patient progresses, they can be performed standing on the balance board to continue to progress and challenge the patient. This device can be used with patients that have visual issues, as well as cognitive and memory issues, all which are common post-brain injury, stroke, and concussion. Some additional technology that is available for occupational therapists to use with patients is called the BioNS. The BioNS upper extremity unit is a device that uses electrical stimulation to improve hand function. It is programmed by the occupational therapist to stimulate the correct nerves and muscles in your forearm and hand, which in turn re-educates and rewires the signals from your brain to stimulate those weakened or paralyzed muscles. It is used for functional electrical stimulation, or FES, as well as neuromuscular electrical stimulation, or NMES. This device pictured here is called the BioNS H200. The benefits of this device include increased hand function, increased or maintained hand range of motion, decreased muscle spasms, decreased muscle loss, muscle re-education, and improved blood circulation. It is designed to help patients post-stroke and brain injury regain their hand function post-injury. Occupational therapists can use this device during their visits to help the patient use their hand and wrist in the correct motion during activities of daily living, or ADLs. OT will then help set up and fit the device. If the patient and the OT find the device useful, the OT can recommend this device for the patient to purchase and use at home. Finally, I'll discuss technology available for physical therapists to use to help patients with their rehab needs. Physical therapists help patients achieve their highest level of functional mobility, including the ability to transfer, ambulate post-injury. After stroke or brain injury, a person's balance can be affected. The device that's listed here on the slide, called the Biodex Balance System, is a device used to test a patient's balance, as well as can be used as a training tool after assessments are completed to work on balance strategies during a physical therapy visit. The device features testing protocol for concussion, called the Modified Clinical Test for Sensory Integration of Balance, or the Modified CATSIB. This test is frequently used pre-season to determine an athlete's baseline, and then can be used post-injury to help determine return to play readiness. The device also tracks each patient's performance during testing and treatment, so the therapist can see how well the patient is progressing with each activity. Just like occupational therapists use the BioNS for the upper extremity, physical therapists can use the BioNS for the lower extremity. This device is called the L300 and is pictured here on your slide. It is designed to assist patients with ankle weakness to the muscles of the lower leg that help lift your foot during walking. It can also assist with weakness around your knee. This helps in turn to reduce fall risk, prevent muscle atrophy from disuse, promote neuroplasticity, improve range of motion, and most importantly, increase confidence and independence for patients. It is two different versions. The one in the photo has a thigh cuff and a lower leg cuff, designed to help patients with foot drop and knee instability after brain injury or stroke. The second device, the L300 Go, is designed to promote recovery of the lower extremity muscles by activating the neuromuscular pathways that are required for gait or walking. It can be used in patients that have a stroke, brain injury, multiple sclerosis, cerebral palsy, or incomplete spinal cord injury. Evidence shows those patients who use this device have a 40% improvement in walking speed, 15% improvement in decreasing fall risk, and 30% improvement in ambulation distance. This picture shows the other option for the L300, which is a lower cuff designed to assist with just foot drop. Similar to the BioNS for the upper extremity, the physical therapist will work with the patient using this device. If the patient finds it helpful, he can purchase it to use at home. Our gym also features the Biodex Gait Training System, which is pictured here. It is a body weight support device that allows a patient to practice walking on a treadmill. However, the patient is in a harness that allows the patient to be safe and prevents falls. The harness is attached to a device that allows the physical therapist to take off weight from the patient, which makes it easier for the patient to practice taking appropriate steps and with less effort. The harness also allows the patient to be supported, which then allows the therapist to help the patient with shifting his weight or by assisting the patient with moving his foot, instead of concentrating on helping the patient stay upright. Research shows in order for neuroplasticity or rewiring of the brain to occur, activities need to be performed repeatedly. Using the harness system over the treadmill allows this to occur. The other nice thing about this device is the harness can turn. So instead of just walking forward, the patient can practice walking sideways or backwards. This harness system, as you can see in the picture, is on wheels. So it can be removed from the treadmill and then used over ground as well. This allows the patient to practice walking on a non-moving surface if he's not able to tolerate using the treadmill. You can also see in the picture the woman is sitting on a stool. These stools are attached to the bottom of the system and allows the physical therapist to assist the patient if they're not able to move their legs. This again allows for repetitive movement in an appropriate pattern to decrease for gait compensations and help the patient relearn a normal walking pattern. Research shows patients with traumatic brain injury that use body weight support system, like the system pictured here, have the potential to allow for greater intensity during therapy and also have better outcomes than patients that undergo standard care. Next, I'll discuss the vector gait and safety system. This is a harness system that is attached to an in-ceiling track that allows a patient to practice mobility in a safe environment. The patient literally cannot fall while in this device. It provides a safe environment and a real-world experience for patients who have suffered a stroke, brain injury, spinal cord injury, amputation, or imbalance. It can be used for patients up to 500 pounds. The vector gait system can be used to help patients in a variety of environments, such as pictured in this slide. The patient is wearing the harness and practicing walking on uneven surfaces and uneven terrain, while the therapist can stand next to the patient and provide support, knowing the device will catch the patient even if she loses her balance. This allows the patient to work on and improve her balance strategies, including hip, ankle, and stepping strategies. This is difficult to perform in other settings, such as the parallel bars, where the therapist would have to be guarding the patient to prevent her from falling. The ceiling track mounts allow the patient to walk and perform these activities multiple times, which also ensures that neuroplasticity is occurring. This is a depiction of the multiple activities a therapist can work on while the patient is in the vector gait system. The therapist can work on not just gait training, but also sit to stand transfers, weight shifting or pre-gait activities, transferring on and off the floor, stepping over obstacles, high-level balance activities such as tossing a ball while sidestepping or standing on one foot, walking on different types of terrain as pictured previously, as well as practicing ADLs. Next, I'm going to show a video. It shows a video of a patient walking for the first time using a quad cane. You can see that he loses his balance a few times, but he demonstrates a pretty prominent kind of posterior backward lean. However, the device is able to keep him upright and the therapist can focus on cueing the patient at his hips for weight shifting. You'll see in the back, there's going to be someone walking behind them. This is a therapy technician, and he's holding a little device. It looks like a cell phone. What it is it's attached to the vector and it can help real time decide how much the vector is helping the patient and if they want to increase the weight or decrease the weight to make the patient do more work. So you can see the therapist is walking next to him and has his hand on his back to help with those weight shifts. And the technician's following behind with the wheelchair and he's holding that device. And then he's real time able to adjust how much weight the vector is taking and can adjust that as needed to help the patient more or help the patient less, make the patient do more work. And this was the first time the patient was able to walk with the cane. So he and his family were very excited about this. All right, so this is the same patient walking. This is the same treatment day. This is going to be him walking without using the device. He and his family were very excited to see how well he was doing after this treatment visit. He was able to walk over 500 feet during a 30-minute treatment session, which is the goal with neuroplasticity, the ability to do things over and over and over again. The device also tracks how far the patient walks, so it can help track their goals and see how much they're progressing. So you can see he's still leaning backwards quite a bit, but the machine is going to hold him, and then he can work on taking those steps, and the therapist can work on giving appropriate cues and not have to be so concentrating and just holding the patient. And his son was there to watch this, and his son had the biggest smile on his face watching him. So you can see he had a little misstep and the machine caught him, no big deal, and he just keeps on going. And finally, I'll discuss the exoskeleton. The exoskeleton is a wearable robotic device that allows a patient to stand and walk in a full weight-bearing reciprocal gait pattern. It is a device designed to be used in a clinical setting and not in the home. It is the only FDA-approved exoskeleton to be used for patients that have been diagnosed with brain injury, stroke, and spinal cord injury. It has software that provides adaptive amounts of power to both sides of the patient's body, which engages the patient during gait training. It allows patients to mobilize earlier and allows for multiple repetitions of intense, task-specific steps for adequate neuroplasticity training. PAM Health Rehab Hospital Fargo is the only hospital in North Dakota that has this device. So there's a significant amount of research that's used to support the use of exo in patients that have neurologic diagnoses. The most recent study was completed in 2020 using the exoskeleton, where 22 patients that had stroke at a rehab hospital were provided with 3 days of exoskeleton training during their length of stay. A retrospective search was completed to match these patients to ones that had received only standard of care therapy. They were matched for age, length of stay, admission FIM score, gender, and hemiplegic side. No additional therapy time was provided for the robotic group. That is, the robotic session was provided as their typical therapy session for that day. Average total distance walked during inpatient rehab was almost double for the robotic group. During standard care therapy sessions, there was no significant difference between the groups of distance walked, indicating that extra distance came during those robotic sessions. Average change in motor film was significantly greater in the group receiving robotic training. In the group receiving robotic training, there was a correlation between total distance and difference of motor film. These results are consistent with the principles of neuroplasticity that I've already mentioned in this presentation, where increased walking dose in the group receiving some robotic therapy led to greater functional improvements. So this is a video of a patient that has had a stroke and subsequent hemiplegia or weakness on his left side. He's walking with a cane, showing kind of a typical therapy session. Then he's going to walk with the exoskeleton on, and then he'll walk without it on. And this is all performed in the same day in the same visit. So pretty typical walking, right? He's got an ACE wrap on his foot. He's buckling like crazy. He's got a tech helping him. The therapist is working pretty hard to keep him walking, scissoring. Everyone's doing a lot of work. And now he's got the exoskeleton on. So therapist in front just kind of helping the guide. Therapist in back just giving cues to help with weight shifting. Already walking much faster. His step length is much more even. There, he's only had one therapist has hands. The other one's just using the controller for the device and giving some verbal cues. This is the same day, no device on. So pretty incredible. All those reps he had with the exoskeleton on, he's already walking better. No change in having a device on his foot or anything. So this is a great side-by-side showing a huge difference before and after. So this is why we're so excited to have the exoskeleton at PAM Fargo, to be able to provide this to our patients in this area, because it's such a cool device. This is one more video of a patient using the exo. This patient had a brain tumor, and after the brain tumor, he had ataxia. Ataxia means a patient has a difficult time placing their extremity where they intend. Typically, without the exo on, he walks about 10 feet during a session. Using the walker requires the assist of 2 people, and it's very taxing on him and the therapist. And then you can see in the video how far he walks with the exo on. This is his first time using the exoskeleton too.
How about this? Can you make it up to the gray up there, the dark gray?
So there's a therapy tech in the front. She's only helping to kind of help guide the walker.
Right step.
On the left, there's a PT, and his job is just to look at the device for the exo and make sure there's an appropriate amount of assist being applied. And then there's a PT in the back, and she's helping with weight shifting. So she's the only one that's doing any actual physical work. As he's walking, you can kind of hear some chimes, kind of a negative tone and then a positive tone. And those are for the patient to hear so they can see if they're doing an adequate weight shift. So it provides real-time feedback for the patient, which we all know is so important.
Right step. Left step. Okay, that?
And shows kind of a nice difference between that previous patient who had very obvious weakness, and with this patient who doesn't really have weakness. He has lots of ataxia. So it can help with multiple symptoms. So you can see the exoskeleton's on his back. That's where the battery device is. And then it goes over both of his legs and onto his feet. So in conclusion, after my presentation, you should be able to recall treatment interventions for decreased ability to swallow, name specialized treatments provided by occupational therapists, list 2 devices used by physical therapists to improve patient function, and name 3 technology devices available to help patients with their rehab post-brain injury. Here's my contact information for anybody that wants it. Now my direct cell phone or my direct number, my email, and then how to get a hold of our outpatient program, and also how to get a hold of our inpatient program. And my references are listed here as well if anyone has questions about anything. I'm going to turn off my presentation so I can get on camera. Maybe we can open it up for discussion questions. Carly, are you able to see me?
I am. You can
Okay.
shut off your total screen share if you want, like hit stop
Yes.
share.
Got
Then
it.
everyone there, and then
Perfect.
we'll go back to the
There you
fun
go.
Brady Bunch style. That was awesome. Wow. I've never seen a lot of those devices.
Thanks. Yeah, that's the
Very
cool thing
cool.
about PAM. We have lots of really great technology here.
Yeah, love it.
Mhm.
We just had a client that was looking for she went to a rehab hospital in Vegas, and she used, I'm not going to know the name, but the one that was on the ceiling, where they were walking. Yes.
Yep.
And we did tell her, you were on the list, I believe, of places when we had asked with, like, I bet Pam has one of those.
Yeah.
So
Yes,
I
we
hope
do.
she got in touch with you guys, but yeah,
Yeah, me too.
that's great. That's great. Does anyone have questions for Chelsey? No, I have one. I can start with questions. So I taught special education before this role, and I taught intellectual disabilities. And with intellectual disabilities, I had heard somewhere along the lines of, like, for your brain to remember it, we need like 11 repetitions without an intellectual disability. But for someone with one, we needed like 111. What for brain injury? What is there a number, or is it just kind of?
There's not a magic number, because that would make it so much easier on us. Once we get to 112, then you
Yeah,
just know.
yeah. Well, and
Yeah,
I don't know that it's exact for intellectual
Yeah.
either, but that was the guesstimate was like 100 times
Yeah.
more than the
Right.
average. Yeah.
Yeah. So
Okay.
neuroplasticity, just meaning you need to do things over and over, thousands of times. And that's why the vector and the harness above the treadmill and the exo are so important, because that patient can just get multiple reps in. That's why we have the ADL room for the patient to just continue to practice, because that's how we learn. Even without a brain injury, that's how we learn. So then with a brain injury, a brain insult on top of that, just more repetition. So
Okay.
that's what it's all about.
How far out post brain injury does neuroplasticity apply, do you think, or do we know?
I tell all my patients that just like you check in with your primary care physician once a year, you should check in with your therapy team once a year, because you can continue to grow, you can continue to learn, and you can continue to reach goals and then find a new goal you want to achieve. So I tell all my patients with neurologic injuries, you should check in with me once a year, just so we can do an assessment, see where you're at, see if things are going well, or if there's things we want to work on. So learning for everyone is lifelong.
Perfect. Good. Good. Molly's got a question. Hi.
Hello.
Hi, Molly.
Very good presentation.
Thank you.
And two things actually. So what you were just talking about. So at Essentia Health, I lead the stroke support group. So we have a monthly meeting. And what you're talking about, I've talked a little bit about it in past meetings about neuroplasticity, but I think what you just said would be really encouraging to some of our stroke survivors, that even long term, you can still do stuff to help activate your brain. So I might have to contact you about maybe coming and speaking at one of our stroke support group meetings.
I'm a huge part of my role here is education. So I'm always happy to do that. I love to do that.
Perfect.
Yes.
And then my other question is, we wind up sending a lot of patients, or I've noticed when we have stroke patients, we send quite a few to PAM Rehab. And I drive by it every day because I live out in Horace. So I drive by you guys every day.
Yes, you do.
And I'm an educator. I'm a lifelong learner. Would it be possible, as somebody who likes to continuously learn, for me to come out to PAM Rehab sometime and take a little tour, kind of spend the day there participating in some of those therapies with the patient?
Not only do I say yes, but I encourage it. That's what we're all about, is we love when people want to come by and say hi and do a tour. We do events all the time. So we just are open door policy always. So please reach out via email and we'll get something set up. I would be honored to do that.
Awesome.
Yep.
And Carly, you're gonna send the contact information, Carly, for her, or
Sure.
it'll be on the, okay, awesome.
Yep, I can do that. Yes, we've been there. So we got to see Pam when it first, well, you guys were Cobalt then, I think.
Yeah.
We got a tour, and it's a very, very impressive, very beautiful facility, and everyone that works there is great. Yeah, so they're more than happy to have you come and visit.
And Carly, it probably looks a little bit different than with Cobalt. So Cobalt's goal, just very briefly, is to build hospitals and then sell them.
Oh,
so
okay.
So it was probably a little bit quieter, not as
It was very quiet. It was a little eerie.
Yeah.
A little eerie.
And that's why. Right. Yeah, and that's their goal. They just build it and then they get rid of it, and that's why we're so glad to have Pam here. So I would love to have you guys come back and see it too, because the EXO we received about 2 months ago, so it's new. Our PTs are now certified to use it and train others on how to use it. So it would be fun for you guys to come see it.
Yeah.
You can get in and walk around a little bit.
We'll set that up for sure. Yeah, definitely. Anyone else have any questions for Chelsey?
Well, I just think it's so exciting that you guys are up and running and doing so much, because for the longest time it was Sanford Rehab or nowhere else.
And that's why we're here, just to provide that support to people in North Dakota. Otherwise, you're driving in Minneapolis, and we serve people all over, patients from Montana and South Dakota. So just knowing that we're here and we're just here to help. And Sanford does a beautiful job too. We're just here to help provide that support to our state, because we need it.
Yes, we do. Now if we can get you all over in little pockets of the state.
Yeah, well, I think that's the goal with PAM. They just keep growing. That's the fun thing of being a part of a large network, is you have all this support and education, but also the fun thing about being in Fargo, it's a very small town feel. It's only 42 beds.
Yeah.
So you know your coworkers well. It's a big team. It's a big family here. So it's a wonderful place to work.
Awesome. All right, well, I don't see any other questions, so I think I'll let everybody back to their work day. But
Sounds great.
thank you so much for your time, and
Thank
Thank you
you.
guys.
great info. Love the videos. That was awesome.
Thank you. Oh, great.
Oh,
Thanks,
yeah.
everyone.
Okay, thank you.
Have a good Wednesday.
You too.
Thanks, Carly.
Bye, Molly. Thank you.
Bye.